Okay, good afternoon, everyone. A clinician, we're not monitoring what we're meant to be monitoring. There's a discrepancy between what we're looking for and what we're doing in response to what we're looking for. And I think this tracks to Barry's set of questions. What questions are we really asking? What information are we expecting back? And part of the reason why I like to come to SPAM conferences is because there's nowhere else you have mathematicians, physicists, data scientists, and analysts all sitting in the same room trying to address these questions as a collective. So if you then ask the basic question, what is the point of fetal monitoring? What are we hoping to achieve? My thoughts on it is what we're hoping to achieve is to be able to anticipate and predict intrapartum fetal asphyxia. Asphyxia here is defined as lack of gas exchange to the point where the baby begins to develop metabolic acidosis. So we're trying to predict that situation, but I've underlined intrapartum to make the point that actually you can admit babies in labor that have already had antecedent insults and perhaps just hovering on the edge of significant acidosis and acidemia. How do we handle those babies in labor? In fact, how do we recognize those babies in labor? So one aim is to predict the onset of that situation and to institute timely intervention and to do it at such a time that the baby does not become injured already before your intervention. But even more importantly, to do all of that without operating unnecessarily on babies that are not at risk. And the reason that is important is because these unnecessary interventions are not risk-free. We make a lot of noises about obstetricians and midwives not reacting to when babies are in trouble. Very little is said about times when we overreact and then impose on women and children the consequences of intervention that they didn't need in the first place. Nobody asks that question. But those of you in practice will recognize that a number of these women will end up with blood transfusion, hysterectomy sometimes, intensive care admissions. And nobody seems to talk about that. In fact, most of those women actually end up buying us sweets and flowers and biscuits. And we enjoy it, that we've done very well. And the other thing it does also is it perpetuates defensive practice. The next paradox is here. And I think somebody already made a point in the house today that intrapartum hypoxia contributes a minority of long-term cerebral palsy and motor deficits. However, if you were to collect the cases where intrapartum care has exacerbated antenatal injury, you come close to 25-28%. But it's important to recognize that hypoxia is not actually the only cause of fetal damage. I put down here a list of the disease states that also result in fetal damage. And I just go through them for completeness. So that is fetal systemic inflammatory response syndrome. So this is equivalent of sepsis in an unborn child. The point here being that that condition damages baby's neurologic setup directly. But even more importantly, predisposes them to damage even by very subtle degrees of hypoxia, including uterine contractions, which in itself is hypoxic in nature. We know that babies that are born to women who run temperatures in labor run a higher risk of neonatal seizures. And it doesn't matter how the temperature came about. It could be infection, it could be epidural, it could be drug reaction, ambient temperature, dehydration. But if a mom runs temperature in labor, the baby is at excess risk of neonatal seizures. Those babies that are born after prolonged periods of rupture of membranes, when there's been histologic chorioamnionitis, host response to that chorioamnionitis characterized by phenicitis, fetal strokes, chromosomal abnormalities. The reason I'm putting this list here is no one knows what the CTG features in these conditions look like. So we've got one tool to monitor babies, but collectively, the conditions that actually impose more harm on these babies, our tool is totally blind to them. And I think if the house is looking for something to do for the next 20, 30 years, this is a big job to do. I suspect anecdotally that our inability to focus in and zero in on what these things look like in terms of monitoring output accounts for the discrepancy between what we're trying to achieve at huge expense and high rates of intervention, and actually the impact that we're making in terms of clinical outcomes. This slide here suggests that most CTG abnormalities are not associated with fetal acidosis. Okay, this study is nearly 50 years old now. It was done at St. Mary's in North London. And essentially what happens here is a collection of CTGs recorded during labor and characterized according to the CTG features. And the acid-base status plotted on charts. Now, 50 years ago, their definition of acidosis was pH less than 7.25. In modern practice, we recognize that 7.25 is pretty generous. But the point it makes is, if you have a normal CTG, particularly if there are accelerations, the chances that your baby will have a pH less than 7.25 is somewhere between 0 and 0. It just doesn't exist. However, if your CTG has the most ghastly features that we do not want, 50% of the time, the baby is completely normal. The other 50% of the time, the baby may be acidotic, as is defined here. So again, the challenge for those of us in practice is, how do you look at a CTG and decide that actually this baby belongs to this group and not that group? In other words, just leave them well alone. But this chart says more, because if you look at this extrapolation of the same chart, so these are the same CTG features you're looking at. And this is plots of the number of babies that fitted into those categories. That is 7.25. So if you drop the line there, this is where they reach their conclusion that most CTG abnormalities are not associated with fetal acidosis. However, if you come 50 years on and put the threshold at 7.10 or even 7.05, which is the threshold below which we begin to think there is significant acidemia, you can now see that nearly all of your CTG abnormalities have little or no association with fetal acidosis. But this is what we react to. This is the basis for practice. So it's not surprising that the more we monitor these babies using our current tools, the more interventions there are, and the less the impact that we make at huge, huge costs. And the reasons these babies are able to do this is because they're engineered totally differently. What I've done here is to take a set of cardiovascular parameters and just compare what's going on in the adult species to the fetus. You can see how very resilient the fetus is in terms of the degree of oxygen deprivation that they can tolerate, how much carbon dioxide tension they can sustain. Their hemoglobin concentration is at least 50% above that of the mom. The ability of their type of hemoglobin to bind oxygen for much longer is much better. They have a higher heart rate, about 2 to 3 times that of the adult. Their capillary density is far more generous, and their cardiac output, Olympic athletes, Usain Bolt will struggle to generate that. But these kids do this as a matter of routine. Not to mention the fact that they have shunts all over the place to divert blood to necessary and appropriate organs. So if you plug all that together, you can see how this fetus is much better adapted and much better resilient when it comes to handling hypoxic situations. Therefore, our tests that tend to look at changes in these parameters, having the adult model in mind, almost underestimates the ability of the fetus to manage these situations. I put this here to pick up on a discussion that came up during this conference. Actually, that there's a direct link between the baby's ability to sustain its central mean arterial pressure and the risk of injury. So when it comes to hypoxic ischemic insults, babies are adapted to react and respond to that by continuing to maintain their central pressure. If that adaptation is successful, the pH is almost irrelevant. The fetal heart rate is not the issue. It is the fact that they can maintain their central pressures, perfuse the brain, perfuse the coronaries, and perfuse the adrenals, the essential survival organs. So what you're looking at here is data from the Auckland group showing the relationship between ability of these fetuses to maintain their mean arterial pressure and the risk of injury and death. So as the pressure, central pressure drops, the risk of injury amplifies until they die as a consequence. So if I was asked to design a monitoring tool that will focus on the questions that we're really asking, I'll be asking, is it possible to actually measure a baby's in the womb central mean arterial pressure? Because if you can zero in on that, it's almost impossible in terms of intrapartum care to inflict hypoxic ischemic injury without going through this pathway. So for me, that is the area to focus in. Now, whether that can be done technically is an open question, and I'll leave that to my colleagues who know much better about this than I do. Okay, so over the last 5-10 years, we published a series of papers that I call the whinging papers. Yeah, and the whole point is to grumble about everything and turn everything upside down and look for better ways of doing old things. Yeah, so I call them the whinging papers. But essentially what it aims to do is to look at fetal monitoring, but from the baby's perspective. So if you can crystallize everything that I've said here into this statement here. This is the only algorithm you're going to see in this presentation. This is the only algorithm you're going to see. And you won't see any equations. And what it says is, if you have a previously normal CTG, in my unit, we only classify it as abnormal or pathological if it's associated with a prolonged fetal heart rate deceleration of 80 or less with loss of variability. Or you go from a normal CTG to a baseline tachycardia of 160 or more provoked by decelerations also associated with loss of variability. Those are the two markers on either side of the baseline heart rate that inform the development of intrapartum evolving hypoxia process. In the absence of that criteria, we allow the labor to cruise. So if you standardize your CTG that way and look at an 8-year data of monitoring babies who are 36 weeks or more, whether induced or in spontaneous labor, without congenital abnormalities, and looking at just under 40,000 babies, about 14,000 were monitored CTG. Our secondary test is STAN. We identified 65 neonatal encephalopathies, not 63, 65. And these are my 2 Italian fellows that assisted in the data collection. And then ask the question, using that methodology for CTG interpretation, what is the frequency of metabolic acidosis? Metabolic acidosis is defined as pH less than 7.05 and base excess of minus 12 or more. So pH 7.05 or less than 7.05 with base excess 12 or more, 1 baby out of 65 neonatal encephalopathies. So what that tells me is you can monitor these babies better. You can reduce the frequency of intrapartum metabolic acidosis. But actually, there's a whole load of other reasons why babies develop encephalopathy, which our monitoring tools currently do not allow us to access. And I think that's where the challenge is. And that's the challenge for this group too. So when it comes to how this operates practically, what does it boil down to? It boils down to our ability to interpret CTG properly. Okay, the value of CTG utility in clinical practice presumes that everybody that uses it can interpret it. And just to remind all of us, a normal CTG should have a stable baseline fetal heart rate. So you could almost put a line through where you think the baseline heart rate is here. The CTG should also have normally periods of reduced variability, which alternate with periods of increased variability. There may or may not be accelerations, particularly during labor. So if you look at this CTG here, you can see increased variability and then reduced variability. And then it picks up again, increased variability and then reduced variability. Now, that feature of increased variability followed by reduced variability and then increased variability, it's a hardwired neurologic behavior of term and near-term fetuses. It's not a random phenomenon. And by that I mean a normal term or near-term baby will not give you endless sequence of increased variability. That's not normal behavior. A normal fetus should have intervening sequences of increased variability, reduced variability, and then increased variability. That's what normal babies do. If your baby is not doing that, it's probably not normal. I couldn't tell you what is wrong with it, but that's not normal fetal behavior. That behavior is what we call the cycling, fetal cycling activity. Now, if your baby shows you that, so a stable baseline fetal heart rate, insignificant deceleration, and cycling with normal variability, you can conclude that your baby is normoxic. That baby is not acidemic or hypoxic, because if you were, it is not possible to tick all of those boxes. That baby is likely to have a normal central nervous system and cardiovascular system with normal pacemaker tissue connecting those two systems to display the heart rate for visualization. Such a baby can react and protect itself from hypoxic insults and also show you predictable changes on the CTG, which you can track prospectively. And those babies, barring the onset of acute events during labor, things like abruption, cord prolapse, and uterine rupture, those babies are at very low risk of developing asphyxia. Now, contrast that to a baby that starts off with abnormal CTG at the very outset. Now, abnormal CTG can manifest as baseline tachycardia. Now, be careful. Those of us in practice recognize that they're not always tachycardic. That tachycardia is a function of how recent the insult is on the baby. In other words, if a baby has survived an acute hypoxic insult several days before, it is possible that by the time they are coming into labor, the baseline heart rate would have normalized. There may be decelerations, but that only happens if there is ongoing hypoxemia or hypoxia. And as mom contracts, then the baby decelerates. But in the absence of, if the baby has recovered completely and metabolically, you may not even see decelerations. But the one thing that marks them out is a monotonous looking CTG. They almost consistently all lack that cycling activity that I described. In other words, the intervening sequences of increased variability and reduced variability. If you were to see a CTG looking like that, here is a list of disease states to consider. One or a combination of these could have happened in utero, and these babies are arriving in labor already compromised. The challenge for the clinician is, what do you do with these babies? Rushing in to do an emergency cesarean section is not going to alter any of this. But the key point here is, if you let them labor, because they're already compromised, they're very unlikely to display the same sequence of events that will warn you that there's onset of intrapartum hypoxia. And they seem to decompensate quite quickly, that you often don't have time to respond. So your challenge really is to deliver them as soon as you can, but certainly not as a rush emergency. Most of them will arrive in what I would describe as static encephalopathy. So my real task was to talk about how non-hypoxic events during labor and the antenatal period can influence some of the adverse outcomes that we look at. I've selected a short list of conditions I want to focus on, and I'll talk about meconium, talk about maternal fever, with or without infection, and then chorioamnionitis. I've got a couple of cases, 2 or 3 cases to discuss, and one of them might highlight the issue with diabetes. The question I posed is the same question I'll put here. Say, how can signal processing and monitoring assist in our ability to detect these? Because the current tools we have, if anything, seem blind to these problems. So if I take meconium to start with, meconium really is baby's shit, to put it simply. Okay, so over the 9.5 months of gestation, the baby's bowel cells, epithelial cells, will desquamate and accumulate and form 65% of the bulk of meconium. But the point is, if you discharge meconium into the amniotic fluid, one of the things it does is to create embarrassment of the umbilical and chorionic vessels. So meconium causes spasms of chorionic as well as umbilical vessels. In high concentrations, it can cause necrosis, ulceration, and thrombosis of those vessels. Now, you and I will quickly imagine that that sort of impact will induce hypoxic challenge on the babies. Now, we've almost always understood meconium discharge as a consequence of hypoxia. Now, animal experiments don't seem to support that. So it may well be that what we're seeing may be the effect of meconium on fetal placental circulation rather than, so it may actually be a consequence rather than a causative effect. The other thing that meconium does is it impairs the antibacterial activity of the amniotic fluid. The amniotic fluid is meant to be sterile, and it does inhibit bacterial growth. But once you contaminate the amniotic fluid with meconium, it impairs the ability of the macrophages as well as the polymorphs to continue to maintain antibacterial activity. And that is illustrated in this study here, which shows the effect of meconium staining of the amniotic fluid on the growth and multiplication of E. coli and group B strep. I won't go through the details of the study, but I'll just show you there one of the panel of their main results. And what you can see here is the colony forming units of bacterial growth against time 0 from inoculation over a 24-hour time sequence. And if you look at the top panel here, where the amniotic fluid is clear, you can see that group B strep can access the amniotic cavity, grow and multiply, even when the amniotic fluid is clear. E. coli is suppressed. Now, this is a unique property of group B strep. That's why it's such a dangerous organism. Once you contaminate the amniotic fluid with meconium at low concentration, group B strep is released to grow quicker and much more extensively. And E. coli growth and multiplication will start to manifest. As you increase the concentration of meconium, the onset of E. coli growth and multiplication gets earlier and greater at much greater concentration. You can see this. So there's almost a dose-dependent effect. From a monitoring point of view, we're beginning to recognize that if the baby has tachycardia in the presence of meconium, particularly in early labor, those babies have a 51-fold the risk of infection. We haven't published this, but we went through a 4 or 5 year period where babies that were admitted with fetal heart rate abnormalities and meconium in early labor, we send their placenta, and almost without exception, they come back with chorioamnionitis. So from a monitoring point of view, one of the ways we can access and identify babies that already have ongoing infection is by their fetal heart rate, particularly tachycardia, and the presence of meconium. Now, whether the meconium is there as a consequence of the infection, or the meconium was the thing that, or the babies passed the meconium because of the infection, is an open question. So if a baby's amniotic fluid is invaded by microorganisms and the baby swallows the amniotic fluid, they just develop gastroenteritis. So they shit the meconium out. So we as clinicians will just see the meconium and we don't know which came first. But the presence of meconium and fetal heart rate, particularly tachycardia, imposes a 51-fold increase on the risk of infection compared to when the amniotic fluid is clear. This is taken from the Romero group, and here they are proposing that fetal systemic inflammation, or fetal host response to inflammation, is actually a potent risk factor to development of meconium aspiration syndrome compared to when the amniotic fluid is clear. Okay. Now again, this is a panel from their main results. These are the markers of inflammation which they use: matrix metalloproteinases 8, and when there is no meconium aspiration syndrome, the median value of this is lower compared to when there is meconium aspiration syndrome. This one I like very much because you may not be able to see it, but what this says here is intraamniotic inflammation, and this says phenicitis. Phenicitis being the host response, or the fetal host response to infection. If you don't have any of these two things, there is no meconium aspiration syndrome. If you have intraamniotic inflammation but no fetal host response, there is meconium aspiration but is low level. If on the other hand you have intraamniotic inflammation and fetal host response, your risk of meconium aspiration is amplified greatly. This is an Israeli study looking at very low risk pregnancies. They don't come any more low risk than this. Okay, they've excluded all the obstetric complications you can think about, including if mom is 35 years old or more. That was considered high risk. And the main results will show that even in that highly selected low risk group, if the amniotic fluid is contaminated by meconium, the risk of intrapartum death, neonatal death, fetal distress, and cesarean section will start to amplify quite significantly. Now, in the UK, there is some guidance, which I think is nonsensical, that talks about thin meconium as being inconsequential. Now, from what I have just said, if you have meconium, you have meconium. it is going to embarrass the fetal vessels and chorionic vessels. It is likely to impair the baby's amniotic fluid and its ability to continue to maintain antibacterial effect. So whether it's thin or thick is almost irrelevant. The risk is the same. And here you can see from even a highly selected low-risk group, once you contaminate the amniotic fluid with meconium, the perinatal outcome will start to alter quite significantly. Now, what about maternal fever? And I've deliberately said maternal fever without infection. Babies will run on average a core temperature of roughly 1 to 1.2 degrees higher than that of the mother. And the baby relies on the mother to have a lower temperature to be able to get rid of his or her metabolic heat. Now, if mom becomes hot, what that means is baby automatically becomes hotter because that temperature gradient is lost. So loss of fetal-maternal temperature gradient is one of the main consequences of maternal fever. Now, how the mother ended up with the fever is almost irrelevant. If mom is hot, mom is hot. And that's not good news for the developing fetal brain. Okay? Maternal fever does not necessarily cause fetal heart rate tachycardia. And that came out in that study that I showed you before. So as clinicians, we should stop making a link between fetal tachycardia and maternal tachycardia or even maternal temperature. If your baby is tachycardic, it suggests that there is something going on with that baby, not necessarily a response to what is going on in the mom. Okay? If mom is hot and therefore baby is hot, it increases tissue metabolic demands. And that increase is what makes those tissues very susceptible to hypoxic damage. Epidural dehydration are the common causes. In fact, in any developed economy, epidural will account for roughly 95% of intrapartum fevers. If you come to my homeland, if a woman runs, nobody gets epidural in Lagos, for example. There are not enough doctors, never mind the ones that will do epidural. So if you run temperature in labor, it's either you've got malaria or typhoid fever or both. Okay? Whereas if it happens in Porto, for example, or in central London, the more likely event is it is due to epidural. But the etiology is irrelevant. If mom is hot, baby is in danger, and we need to recognize that. Maternal fever is an independent risk factor for neonatal encephalopathy, as well as hypotonia and the need for resuscitation. That comes across in this study by Lieberman, very well known, that shows a 3 to 4-fold increase in the risk of neonatal seizures in women that run unexplained fevers during labor. And the higher the fevers, the greater the risk of things like hypotonia, long-lasting hypotonia, need for ventilation, 1 and 5 minute ABGAS calls, as well as seizures. Now, chorioamnionitis, in other words, a situation where the baby's placenta and tissues have become invaded by microorganisms. And this is what the baby confronts, a whole series of baby's tissues suffering from the host response to that infection. Okay? And this is why these babies are such major risk of organ damage from the inflammatory process. How much time have I got?
5 minutes, but that includes discussion.
Oh, okay. All right. So let me run through this. Okay. Now, the reason we should worry about fetal infection is because in the presence of hypoxia, you end up with this synergistic injury. That means that the magnitude of brain damage that you see is in excess of what you would normally expect if it is just hypoxia or just inflammation alone. So I'll skip that. I put this slide here to draw your attention that the use of fetal blood sample to try to risk profile the baby if you're suspecting infection is not a good idea, because there's no significant difference in acid-base status between the babies that have infection and the ones that have no infection. Whereas if you ask a question about neonatal adaptation in terms of APGAR scores, you can see that the ones that have infection will have a significantly lower APGAR scores at 1 and 5 minutes. Okay. I just want to show you one or two cases of what I'm describing. So, this is a baby that is admitted in labor. You can see the CTG here. Barry, I'm sorry, this is 1 centimeter per minute. So it might be a challenge for you. But you can see that the baseline rate is within normal limits. The variability just crosses the border of what we describe as normal. So 5 beats per minute or more is normal. If you follow this CTG on, it looks the same. It looks the same. If you apply the regulatory guidelines to this CTG, it will pass because the baseline is normal, the variability, there are no decelerations. But normal babies do not maintain such a monotonous CTG. That is the problem. And the other thing you may notice is over time, the variability will begin to improve. Variability increases because there's an additional hypoxic challenge because of the labor. It is not because the baby is beginning to recover. So this carried on, and eventually she went to theater. Even in theater, the variability looks better. It's not because the baby is recovered, but because increased variability is early onset fetal response to hypoxic insult. And when the baby was born, that was the outcome. Okay, so it wouldn't have made any difference if you delivered this baby within 10-15 minutes of admission. This event already happened. It is just that the CTG in its current form and given our current tools does not allow us to monitor these babies any better. I have a few more, but Diogo won't let me, so I will skip all of this. I'm happy to take them at the question, and I'll just go back to my concluding slide, which is here. And just to say, what can you guys do to help? Thank you for your attention.
Thank you, Austin. Yeah, sorry about that pressure, but it's Antonia. She asked me. Any questions? We have.
I wouldn't send her.
We passed the chance for the announcements we wanted to make.
I wouldn't send her a Christmas card for it.
We have to move them later. I don't know.
Thank you very much. I expect the answer is no, but maybe you can give a more nuanced no. Is there any way to infer the timing of the meconium when you detect it at birth? In other words, is there any way to know how long the fetus was exposed to the meconium?
Yes, there is, but not until the baby is born. So after the baby is born, and if you send the placenta to histology, quite often they can tell you just by impregnation of the membranes with the pigments in the meconium. They can tell you roughly how long the baby is exposed to the meconium for. And the other thing that happens is you also have scavenging macrophages that mop up those meconium. And when they mop them up, they end up in the amnion and the chorionic layers of the fetal membranes. And that transport system takes hours to days. And they can just by measuring the intensity guesstimate roughly how long the baby is exposed to meconium. So if you have a good perinatal pathologist, they're often able to give you some indication.
Is that kind of information available routinely?
Well, it should be, as I said, if you have a good perinatal pathologist, but you have to ask them that question. Otherwise, there will be no need for them to comment on it.
I have actually your question. In the best of worlds, what is the best way that the SP part of SPEM can help?
How much time have I got?
You don't. No, come on, it's important. But yeah. What can I do? Don't look at me.
1 minute.
We are failing with time.
It's an ongoing conversation. I have to say, 2 years ago and 2 years before then, these questions still came up. for me personally, the more I think about it, the more I think there are so many input sources, number one. But it seems to me that at least during labor, one final common pathway towards injury is degradation of fetal mean pressure. And if we have a tool that is able to access that biomarker and concentrate on it and warn us in advance, we might just be closer to the answer to the question. As it currently stands, those examples only exist in animal models.
Okay. Do we have time for? Are there any more questions? Because we started something like 10, 15
Don't
minutes
worry.
late. So could we? I mean, do you want to do something else?
Yes, we do.
Yeah.
So